Good morning from the Hawaiian Eye Conference in the Big Island of Hawaii. We're pleased to have Dr. Ken Beckman from Columbus, Ohio, one of our ASCRS Cornea Clinical Committee chairs. Thank you so much for, not chairs. You're not, are you the chair?
I'm not the chairman, but I'm on the committee.
I'm going to start over. This is where the live audience is probably like, holy.
Fortunately, there's only one person watching.
Yeah, there's only one person watching, and it's Julio. And maybe his wife or something. Good morning from the Hawaiian Eye Conference in the Big Island of Hawaii. We're pleased to be here with Dr. Ken Beckman from Columbus, Ohio, one of our ASCRS Cornea Committee members. Thank you so much for being with us today, Ken.
Thanks for having me.
Ken, I'd like to speak with you this morning about ocular surface disease, dry eye. This is a really challenging disease to manage, especially for physicians like us who live in very cold weather climates,
right,
where dry eye is really prevalent, especially for the 5 or 6 really cold months of the year. We have some great treatments out there. We have prescription eye drops such as cyclosporin and lifitegrast. We have omegas. We have punctal plugs. Of course, good artificial tears. But I understand that you are studying a new item to add to our toolbox. Tell us a little bit about what that is and how it's important.
Yes, and I agree there are a number of good options, but sometimes that's still not enough. So a group of us, there were 7 or 8 physicians that did a retrospective analysis earlier this year looking at the use of amniotic membrane cytokine extract drops. So this was created or prepared at a tissue bank, or at a compounding pharmacy, I should say, and patients were treated over a period of 12 weeks. Each patient received the drops BID, and they were checked at weeks 4, 8, and 12. To give you an idea of why we use this, the amniotic membrane extract we know has a number of anti-inflammatory components and growth factors that help heal the surface, much as we see with serum tears, for example. And so this is an inflammatory disease. We were trying to come up with another type of anti-inflammatory treatment. So for these patients, we looked at a visual analog scale for their symptoms and corneal staining with fluorescein, conjunctival staining with lysine green. And fortunately, at all 3 endpoints, 4 weeks, 8 weeks, and 12 weeks, at all 3 data points, they met statistical significance and improvement in all 3. And it continued to improve at each endpoint.
So I guess, Ken, I'm curious, since we already have anti-inflammatory prescription eye drops available, where does this fall into your treatment regimen? Is this a replacement for treatments that are already in existence, or is this an addition to treatments that patients may already be taking?
Well, ordinarily, a patient is going to use what's commercially available. I think that makes sense. So whether it's cyclosporin or lifitegrast, that's a great start, along with artificial tears. Some patients may not tolerate one, may not be able to fill it for whatever reason, or they may just get incomplete effect. Just as a glaucoma patient may have a pressure of 40 and one drop may lower them to 30. That does not mean the drop didn't work, it just means they need additional treatment. And we have some patients on 4 glaucoma meds. Sometimes they need 3 or 4 dry eye meds. So usually it's going to be second, third line further down the road, but it can be very effective.
Well, that's a really good point. I wanted to ask you about the timing of the study. You mentioned the patients were studied for 12 weeks. Does this mean that the treatment is meant to be a 12-week treatment and then completed, or was that just a window that you studied and this is the type of medication that should be continued for a longer term?
Well, no one really knows, as there have not been the detailed studies yet, the prospective studies. I have a number of patients that stopped and felt better. I have a number of them that wanted to continue. And they're welcome to, just like with serum tears, we may keep them on indefinitely. They may go through periods of time where they'll use it and they may stop for several months and the next year come back and say, I'm flaring up again. So no one really knows. We need to do the prospective studies to really look at it. But at least in that window that we looked at, they seem to get a really nice effect.
Well, this sounds like a really great study to evaluate the adjunctive effect of amniotic membrane extract to other existing dry eye therapies. I'm so glad you're able to share your expertise with us today. Thank you.
Thank you. Thanks for having me.